Welcome everybody in this after webinar of the WFUMB, the World Federation Ultrasound in Medicine and Biology. My name is Dieter Nürnberg. My hometown is not far from Berlin in Germany, and I'm sitting at home. We have home office in this time, you know that. And our program for today is to give a seminar, a webinar about interventional ultrasound, INVUS, that is an abbreviation. Interventional ultrasound you can use bedside or in a special room, and you can use it for diagnostic and therapy and so on. And it's a very good method to learn it. And we like to give you an introduction. That is the first part, and the first speaker is Thomas Muller. And Thomas Muller, he is now working in Wiesbaden in Germany too, and he is also a gastroenterologist, a consultant doctor in his hospital, and he has a large experience in interventions. And the next speaker then will be a surgeon, a visceral surgeon, that is Matthias Wüstner. We hope that he will join our meeting then. And that is a special idea of him, that the surgeons, the interventions themselves and the name for that procedure in the hand of the surgeons. It could also be in the hand of gastroenterologists, radiologists, or whatever, is surgical interventions or sonosurgery. We can discuss, or you can ask him about that. And the finish is then my presentation about a special topic that are biliary interventions in situation of acute cholecystitis or in biliary obstruction. So now let's start. And we have now more than 100 participants. Welcome everybody. We are very happy to see you. We start with Thomas Müller, and Thomas Müller about basic principles in ultrasound and some special topics about this procedure. Welcome to.
Welcome everybody. I hope that you can hear me. For me, it's a new experience. It's my first webinar, and I'm quite happy that we have the opportunity to give a lecture digitally transmitted. And I would like to take you to a journey into the beginnings and the basics of interventional ultrasound. And first of all, there is my disclosure slide. I have no conflict of interest. And what happened 1,000 years ago? I take you back to Spain 1,000 years ago. There was a famous physician, Abul Qasis, and his desire was to get into the body and to get specimens out of the body. He invented many instruments, as you can see on the left side, for taking biopsies and probes and specimens out of the body. That was 1,000 years ago. Imagine that. His disadvantage was, however, he didn't know where he had to puncture unless he did palpation. So the desire to get specimens out of the body is pretty old, and today's applications are quite modern. Today we want to get biopsies out of the body. We use different kind of needles, as you can see here, suction needles, true cut needles, or pincer needles. We want to place drainages into cavities, abdominal cavities or pleural cavities. We want to do IV lines, and of course we want to do locally ablative therapies. All these applications are today's portfolio of what we have at hand. And what do we need? What do we need for these interventions? We need good guidance. Ultrasound seemed to be a good idea as a guidance tool since the 1960s. In Austria, Kratochwil and others started to use ultrasound as a guidance tool. And as you can see, there were many pioneers and publications in the 1970s who tried to use ultrasound as a guidance tool. Here you see some images of ancient ultrasound transducers used as guidance tools, and they look a little bit like, well, 20th century, and in fact they are. Since then, The development has been rapid, and I will show you some of the most modern tools we have today. But first of all, let's think about what is it all for? What do we want? We want no harm, and we want the benefit of the patient. So there has to be something good in the end of our procedure. And for that, we need safe access and we need good needle control to avoid any damage of vital tissues. What we have at hand are our hands and eyes and brain. This is everything we have at hand, and we can make use of it. And we have mechanical devices. In the recent years, we got an increasing amount of electronic devices too, and these are the three things I want to show you. What is the most important thing to do with our brain is, first of all, a thorough examination of the aim of our target and of the surroundings. Ultrasound examination before planning a biopsy is mandatory, of course. Where is the target? Can I reach it? And what is around? If, for example, we have a cystic lesion of the neck, and puncture seems to be easy, but be careful. Maybe you put on color Doppler in advance and you realize that that cystic lesion on the right side of the image is a large vessel. You would better not puncture. So what is the safe access? It's from the left side of the image here. So thorough examination of the thing. Know where you want to go, know what you have to pass. And when you are sure that this is a good way, then go the next step. For example, here you see an intercostal approach from the right side, the liver, and in the deep liver we see a lesion, bullseye lesion, seems to be a metastasis. Of the no planning means we have to measure the distance from the surface to our target lesion and of course the size of our target lesion. Distance here is 8.2 centimeters and the target lesion size 2.7. We have to know that because we have to adjust the puncture depth and choose the right cannula. And when you have measured that and examined everything, you can perform a safe biopsy even in a deep liver lesion. Which kind of guidance tools do we have at hand now when we talk of ultrasound? First of all, there is the most simple approach is you do ultrasound of a liver lesion, then you put away your transducer and you perform the puncture. The second approach is you do ultrasound of the liver lesion and at the same time with your other hand place a needle, and you can choose the free angle if you have a free hand. We have applicators that can be fixed to the transducer, to the probe, and of course we have dedicated puncture probes. We are not talking about that I do ultrasound and I put away the probe and do some puncture. No, we are talking about ultrasound guidance. And here I would first of all recommend the freehand technique. What is freehand technique? There is no applicator, there is no dedicated puncture probe, you just have your transducer, a syringe, a needle, whatever, and both your free hands. And as you can see here, you can choose every angle and you're quite free in where you want to do the puncture. So there are two different principles in freehand puncture that you have to know by heart. You see the difference between the two images. On the left side, we have the in-plane technique, and on the right side, we have the out-of-plane technique. What is the difference? The difference in imaging is, of course, when we examine our needle in ultrasound plane, we can see the needle and the whole length of the needle. In the out-of-plane puncture technique, you can only get a cross-section of the needle. As you see at the arrow, there is probably not the tip of the needle, but it is a cross-section of the shaft. So, choose yourself. What would you prefer? Complete needle control in the in-plane technique or out-of-plane technique and see a cross-section? I would recommend the in-plane technique in almost all circumstances. Out-of-plane is sometimes used when you have small vessels like an artery here to puncture an artery. For example, here. Unfortunately, the video is not running. Sorry for that. In-plane needle guidance means we place the needle on the transducer, on the transducer's small side, and then propagate the needle in the plane. So here it is. This is the area out of our image. This is the area before the target, and here is my target lesion. I have to be aware of these three parts of our needle route. We need careful examination in the red area before puncture. Maybe there is an interposed vessel. The yellow part of the track is not of relevance because it's out of the goal, out of the target. And the green part is the target. So the green part is the puncture depth we have to adjust. Here we see a very thin plane. In plane means thin plane. It's only 1 millimeter or 2 millimeters, and we have to keep the needle in the plane. When you sweep the transducer from left to right side, you can see on the small image in the left upper edge, from time to time you see the needle. So this means in-plane needle placement is always going on with slight movements of the transducer. Sweep through the tissue in order to keep the needle inside till it's in the goal and has reached the aim. Sweep the transducer to both sides and maybe change the angle of the needle from time to time in the tissue. It's only very, very small movements with both your hands. You will get used to it. If you can close your shoelaces, you will be able to do freehand biopsy too. This is an old publication from '96. It's 25 years of age, and this time gynecologists and radiologists made up their mind on how to perform breast cancer biopsies at best. And what you can see here, it is of importance, what is the angle between the needle and our beam. And when the angle is almost perpendicular, 90 degree on the right side, you have the best needle visualization. Of course, aside from the mamma, from the breast biopsy, it is hardly possible to have a 90-degree angle, but try to get the angle as large as possible in order to have better needle visualization. You can use specially prepared needles to improve needle visualization. Here is an example of a needle that has special applications at the tip in order to improve needle tips. And if you know how to do it, then in-plane technique is pretty safe. On the left side, you see a very deep biopsy of a pleural lesion, 10 centimeters in depth, and needle guidance is absolutely safe. Whereas on the right side, we have a superficial tissue that is biopsy is done here, and the angle is very flat. So what you can see here is on the right side, a flat angle and a very good needle visualization, and a steep angle on the left side, when we do that pleural biopsy, and visualization is a little bit poor maybe, but we know where the tip is. What you see here is stay in plane, try to flatten the angle, and then go ahead. One of the very good applications is central venous line placement, IV line placement. Here we have a flat angle. Here we see the needle tip, and we know now we're in the vessel. And it is easy to place the guide wire then, and we have a fine visualization with a flat angle in the in-plane technique, just to show you an example. Training, dear ultrasound friends, training should always be on a model and not on a patient. The model can be everything. It can be an apple, an olive, a piece of meat, whatever. And you do your training maybe at home, maybe with a person who is very well trained already. You can cook your own jelly, or you can use more sophisticated models. When you start, please don't start on a patient, but start on some pudding or jelly or whatever. If you have mechanical advices at hand, biopsies will even be easier. We have those needle attachments that will be placed at the outside of the probe with a fixed guidance. And here you see we have a liver lesion, we have a biopsy channel here, and there is the needle. Here is the lesion, the target lesion, and it is advanced through that fixed attachment, and you can hardly miss the lesion when it's in the dedicated lines here, between the dedicated lines. This is the advantage of an attachment, And even more sophisticated are dedicated biopsy transducers, which with a central perforation for your needle. They are very expensive. They have to be sterilized after each use, and of course they're very convenient, but they are expensive, and sterilization is time and money consuming. If you have it, of course, you can use it very well, and you have a good needle control. Here you can see the needle placement, bam, biopsy is taken and finished. Very fast access, but now the transducer has to be sterilized. This is the visualization you get here on the right side. You see the needle is coming from the center of the probe. The disadvantage of biopsy transducers is obvious. You will never have a steep, you will always have a steep angle. You will never have a flat angle. So needle visualization is mostly poor. Anyway, if you have it at hand, you can use it. And of course, in recent years, electronic devices emerged, and we have electromagnetic needles. There are various kinds of electronic control of needle trajectory and tip. We have GPS systems, electronic controls of target, and we can combine ultrasound biopsy with fusion imaging, for example, to perform biopsies of lesions visible only in MRI or CT. Here we have an example of a needle tracking in plane, electronic needle tracking. Here is the needle tip. It's very well controlled. The trajectory is given as a green guidance line on the screen. We have a volume navigation out of plane. If you have volume navigation here, that little box on the left side, the GPS signal. The GPS signal shows you where your needle tip is, and you can even do it out of plane. Here you see the yellow box is showing the needle grip, the green circle is the needle tip, and the blue box is the needle aim, where it's heading to. So we have two planes that are simultaneously displayed. This is very sophisticated. I don't use it because, to tell you the truth, we don't have the time and the money to always prepare patients for that. Needle tracking can be done electromagnetically, like here, an image I got from eZono, where the needle is tracked by electromagnetic radiation. So you can see here you have that artificial visualization of your needle trajectory on the image, which will help you to get your needle into your target. What is fusion imaging? Fusion imaging combines two imaging modalities. That means we have our ultrasound image, and the other one, MRI or CT, has to be done prior to ultrasound. We have to have the data from the other examination, and we need volume navigation. That means we have to have a 3D or GPS-based navigation. Where is our needle in the three dimensions? If we have it like that, then we have everything at hand. We can combine here, for example, a CT scan and ultrasound image in order to puncture or to do a biopsy of a lesion that is poorly visible in ultrasound but very well displayed on the CT scan. And the ultrasound image is live, real time, whereas the CT scan has been done in advance and is now shown as an overlay image on the screen of your ultrasound machine. As you can see here, it's very convenient if you have it. Quite sure that you will meet your lesion or hit your lesion, but it is, well, I don't know if it's really better than the freehand technique, but what I want to do in this lecture is to give you an overview of everything that is possible and that we have. We have fusion imaging of ultrasound and contrast-enhanced ultrasound, for example, contrast-enhanced ultrasound done in advance with volume navigation and then later without. And here you have on the right side the contrast image, on the left side you have the grayscale image. In the grayscale image alone you wouldn't be able to see the lesion, but in the contrast ultrasound image it is very nicely depicted. So fusion imaging is two possible. Freehand or not is one of the questions which ultrasoundologists can have a long debate on. The advantages of the freehand technique, which I showed you in the beginning, one hand the transducer, one hand the needle, in plane technique, is it is very cheap. All angles are possible. It is repeatable endlessly. The disadvantage is it is a little bit difficult to learn for the beginner. So the learning curve is not steep. It's a flat learning curve. It takes you some time. Needs a longer training period. And in the beginning, it has a lower success rate, only in the beginning. So I would recommend to do freehand because it is very cheap and it allows you to get a good angle to almost every lesion you want to get. Well, keep in mind, if we can't see the target in ultrasound, we have other imaging modalities at hand, for example, for pulmonary lesions that are not reaching the pleural surface. We have CT guidance, or for lesions in the retroperitoneal space that cannot be reached by ultrasound. Don't be shy, ask your radiologist, or if you are a radiologist, use your CT scan. But in most cases, ultrasound guidance is a good tool. And in order to have a safe procedure that does not harm the patient, we need ultrasound guidance of the needles. Guidance can be achieved best in the in-plane technique. Place your needle in the center of the short side of your transducer and advance it slowly. Move your probe fan-wise very slowly and move the needle very slowly and try to get the whole needle on the image. This is what is the first thing you should do in the training. The in-plane approach, I was talking about it. And freehand guidance is very cheap and after some training is very fast too. It's much easier than to build up the whole equipment you need. Mechanical guidance tools are very helpful. And of course, if you have at hand, electronic guidance is very nice to have if you have it. I wanted to give you a short overview of the basics of interventional ultrasound. No matter what you do, what kind of intervention you do, simple biopsy, locally ablative therapy, drainage placement, the principle is always the same. Keep the needle inside and know where you are going through. And this is the basic part of our training. Cook a jelly or a pudding and try to hold the needle in plane, passing your pudding. Thank you for your attendance.
Okay, I hope you can hear me. And I look, are there some questions?
The first questions, what kind of the disinfection you use for this kind of interventional ultrasound? You should be sterile as in a surgery room.
A very good question, because we use a very sophisticated hygiene regime depending on what we do. If we do a simple biopsy, for example, of the thyroid, without any placement of drainages or whatever, we use disinfection of the skin, disinfection of the ultrasound probe, of course, and the sterile needle. That's everything. If you place a drainage or an IV line, if anything is going to stay in the body, of course, you have to work like in a surgical operation room, yeah? Like in an operation theater. Make a difference between simple interventions, like, for example, venipunctures or complicated interventions, locally ablative therapies, drainage placement, IV line placement, like in surgery. In fact, last year we published, 2 years ago, we published very sophisticated recommendations for hygiene on interventional ultrasound. They were published in English and like download this for free. Or if you recommendations on infection control on interventional ultrasound. Google that, you will find the recommendations of the German Ultrasound Society. Download it for free, it's English, written in English. So.
The second question is, what experience does the Dr. Muller have with fusion system where ultrasound imaging is live combined with TC, MRI scan in practice, biopsies, clinical experience?
I think the most important application of that fusion imaging in biopsy is at the moment the prostate biopsy in men. When you look for prostate cancer is hardly visible on the ultrasound image, but very well displayed on MRI. So what we do now is we combine MRI imaging of the prostate with a real-time endorectal ultrasound scan of the prostate, and then we can easily locate the suspicious lesion and place the needle in there. So this is, in my opinion, the most important clinical application of fusion imaging in interventional ultrasound at this time. I don't use fusion systems, very rarely use it, because most of the lesions I want to perform biopsy on are visible on ultrasound. You have to do sophisticated ultrasound, and the second indication would be if, for example, there is a liver lesion visible only on CT scan and not on ultrasound, and I want to perform ultrasound guided puncture, but I rarely do it. So prostate biopsy is the most important indication for fusion imaging in interventional ultrasound at this time.
Okay, another question is, do you have any tricks to see the tip of the needle during the difficult US penetration visualization?
First, the needle tip visualization is easy when you use the in-plane technique. Yeah? On the small side of the probe, insert your needle here. When you use the out-of-plane technique, you don't know where the needle tip is. You have to fan your beam in order to see the needle tip. Needle tip is here. But when you get a cross-section here, well, if you use the out-of-plane approach, you always have to follow the needle tip. When you use the in-plane approach, it is quite easy. Good thing is to have a flat angle, not a steep angle, but a flat angle. And of course, if you have the opportunity, you can buy specially prepared needles with a riffled surface, which are much better visible. And of course, think of the basic adjustments of the grayscale image. That means lower your frequency and increase the depth of the image, of course.